Kenapa tak boleh Saya stop sharing dulu. Sharing, tutup ini. Okey, dah start ke live streaming? Streaming nampak tak? Okey, ada.
Okay. Good afternoon, Prof.
Good
Tila.
afternoon. I was trying to get the background on.
Yeah, it looks
Yeah,
it looks well. It looks fine.
yeah,
Okay. We are going to start now, yeah, Prof. Yeah? You okay? You ready?
yeah.
So we
Can I
have
share screen?
yes, you can share your screen. Let me just give some introductions. There are a few participants here already. I
Yeah,
think some
yeah.
of you also listening from our Facebook accounts. So greetings and warm welcome to all attendees, participants today. Thank you so much for joining us. I'm sure this will be another very insightful webinar by Maso. Your presence is really important for us in a way of supporting our our activities, our programs, and also for you to learn new insights and information knowledge from our amazing speakers today. Yeah, we have 3 speakers. Um, our distinguished speakers are ready. They will be sharing their valuable insights, and we encourage your active participations as well. So in case if you have any question, please, those who are here in the Zoom, please you can type in your questions in the chat box, and those who are in Facebook, you can also leave your comments, and we will pick it up from there. Yeah. So let's make this webinar very much interactive session, a very collaborative and engaging platform for all of us to know more about obesity. Yeah, and this year's theme is theme is about let's talk about obesity and youth. So so it's about obesity and youth. So if you have any burning question in regards to this, yeah, please share with us, and we will try to answer your questions and give more information about your questions and so on. So thank you once again for being here, and let's make the most of this opportunity to expand our understanding and also to connect to each other. I know this is not a physical seminar, but it's a webinar where you can be known by by being more interactive. Yeah, so enjoy the session. Let me first introduce our first speaker. Okay. Prof. Dr. Tilakavati Karupaiah, who is already here. Thank you so much, Prof, for accepting our our invitation to speak in this webinar. Prof. Tila is herself is a professor, research professor at Taylor's University in Malaysia. She was formerly head of dietetics program, National University of Malaysia, UKM. Research program is related to health and disease, bridging human clinical trials to epidemiological way of the nutritional epidemiological studies to the food environment. Yeah, she's well known for work on cardiometabolic health. Yeah, and she have contributed so much for our dietary guidelines, especially for the recommendations of fat intake. Yeah, and also she have contributed to the global dietary database. And before that, she has worked so much extensively in the field of chronic kidney disease research, both as an educator. My lecturer previously, yeah, Prof, she taught us dietetics student about this kidney disease and dietary lectures on this, and she was the first Asian, in fact, to receive the Joel D. Koppel Award in 2017 from the National Kidney Foundation USA for a significant contribution in this renal nutrition field. Yeah, she is now very much engaged in the prevention of obesity and the NCDs through food policy research and collaborates with Informas. Yeah. Network for capacity building in the area of food environment research in Asian countries, and she have done recent study about was it on the advertisement involving several multi countries. So amazing CV there, Prof. And she is still very instrumental to Maso. We have recently worked on our SPOM document. SPOM stands for Strategies to Prevent Obesity in Malaysia, and she is one of the very important lead writer for one of the chapter in our document. So today she is speaking about this, yeah, strategies to prevent obesity in Malaysia. And over to you, Prof. Tila.
Firstly, I must thank Dr. Geeta, for such a very too generous introduction, which sort of embarrasses me. Now, I think I really appreciate the opportunity to be given this platform to talk about obesity and why preventing or reducing obesity is very, very critical. I'm not going to talk about why, but how to, in terms of it requires many, many strategies from many areas, which I'm going to talk about. And let me say this. Let me switch to the presentation mode. Okay. So it's a very, the aspect of obesity is so tremendous that when we talk about reduction, it requires many, many stakeholders and strategies. And it's not an easy thing. It's a very complex action. Now, I'm going to talk about the main aspect, which I'm going to cover here in my introduction. Multisectoral engagement, intersectoral partnerships, public-private partnerships, and role of civil society. Then I'll progress to economic activities of government, policies and programs influencing obesogenic environment, monitoring and surveillance, which is very critical, and I will end with equity and inclusivity. It's very important, and sum up all the my summing up will include a mapping of all these strategies. Now, to begin with, this is the term that we are going to be, I'll introduce throughout, AOR, or the Agenda for Obesity Reduction. We're not talking about prevention, but we are talking because prevention means from ground zero, but reduction means what can we do to bring down the rates, obesity rates from Malaysia. To start with, the biggest aspect comes from policies and commitments from the public and private sectors and civil societies. Now, a high body mass is very, or rather, alone itself contributes to about 9% of disability-adjusted life years, what we call DALYs, which is linked to NCDs. So you can essentially recognize that obesity is a co-joint driver in public health policies when we talk about tackling NCDs. Now, in this context, government policies and programs are very critical in two areas. One, supporting a healthy food environment to address dietary risk factors from the big four nutrients, namely calories, fat, sodium, and sugar. And the other aspect is to provide settings that promote physical activity. Now, without doubt, the Ministry of Health is the largest stakeholder in driving policies to tackle obesity and NCDs, and has been doing this through the National Plan of Action for Nutrition of Malaysia, NPAM3. It's due to end next year, but probably it will get a revision. Now, in particular from NPAM3, the fourth strategy is dedicated. There are 16 activities here dedicated to the prevention and control of obesity and diet-related NCDs. Now, we also have in development the reviewed nutrition POCO on the policy options to combat obesity in Malaysia by a task force, and this is in place right up to 2030. It offers 44 policies in 5 main settings, covering childcare centers to the general population. And it's important to note that this has consultation from 24 ministries, professional bodies, NGOs, and industry. Now, it's when we talk about the multi-sectoral. Okay, anything? Yeah. So when we talk about the multi-sectoral action of government for promoting healthy food environment towards the agenda for obesity reduction, or AOR, the most important question is to ask is, are relevant ministries as stakeholders doing enough to enable healthy food choices? I think that's about the most important aspect when we look at these programs. Now, this was addressed looking through the Food Environment Policy Implementation Assessment called Food EPI. It was conducted from 2016 to about 2018, 2019. And Food Happy identified 13 ministries in government as key stakeholders in the food environment of Malaysia. And these sectors that have a direct impact on AOR and opportunities for further strengthening or introducing new strategies are the ministries of health, education, domestic trade and consumer affairs, international trade and industry, housing and local government, agriculture and food industry, home affairs, communications and multimedia. Now, Food Happy looked at specifically 7 policy areas: food composition, labeling, food promotion, food prices, food provision, food retail, and food trade and investment. And what we see here, specifically for the policy domain, starting with food composition, our recommendations are setting mandatory targets for the nutrients of concern related to packaged processed foods and beverages. And these probably are likely to include ultra-processed foods, provide for a mandatory declaration of the nutrients, calories, fat, and total sugars for menu labels for meals sold in public settings, ensure the food industry is compliant to nutrient targets consistent with the WHO and/or the Ministry of Health goals, update the food composition table, that is a MyFCD, which is an ongoing process, and provide a dedicated fund to ensure this process is continuous. Now, the ministries engaged here are the Ministry of Health, the International Trade and Industry, and the Prime Minister's Department. Moving to food labeling, another domain, the recommendation is to declare added sugars to be included on food and beverage labels. That's missing. And to ensure menu labeling, that is a menu board and online services, including the direct delivery services. And the ministries which are involved here, the stakeholders besides MOH, are the domestic trade and consumer affairs. Now, the strategy here is less calories, less sugar, less fat, and that needs to be achieved. Now, moving to food promotion, mandatory policies and governance need to be progressed for food marketing and advertising. That's very, very critical. Regulatory framework involving multi-sectoral engagement for governance, the control of billboard advertising by local government, broadcast TV advertising, approval provided by the Film Censorship Board, a directive order to restrict in-school marketing to children. So these aspects, the regulatory framework needs to ensure this engagement across the stakeholders. Now, also, the WHO nutrient profiling system and recommendations need to be adopted as regards restricting unhealthy food marketing and advertising to children. These are the multi-sectoral engagement would be, besides MOH, communications and multimedia, Ministry of Home Affairs, Housing and Local Government, Education. Again, the strategy, AOR strategy, is to reduce exposure to unhealthy food marketing and advertising to children for this domain. Now, food prices. Essentially, the recommendation is to increase excise duty of SSB to 20%, expand duty and excise to other foods and beverages, the premix, cordials, condensed milk products that are high in sugar, prioritize the local agriculture to enable self-sufficiency, consumer access and affordability of fruits and vegetables, establish a supply chain for food and vegetables to minimize cost-bearing factors and taxes to ensure consumer affordability, provide subsidies to target food and vegetable consumption for B40 households. So the multi-sectoral engagement here would be, besides the MOH, the Ministry of Finance, Domestic Trade and Consumer Affairs, Agriculture and Food Industry. In terms of food provision, the principles of food provision policies need to be aligned with NPAM3, WHO nutrient profiling systems, and WHO's SDG goals. The multi-sectoral engagement required here would be not just the MOH, but education, housing, and local government. So the AOR strategy is to discourage purchase of sugary foods and beverages, increase access and affordability of fruit and vegetables. Going to food retail, stricter policies and zoning laws are needed to support a healthy food environment covering the 24-hour eateries, fast food outlets, and the license approval for these. Discourage discounts and bulk deals when purchasing unhealthy food and beverages. This regards the online merchants, and to encourage discounts for healthy foods, the other side of it. An example would be as the Eon's Nutri Hub. Now, the multi-sectoral engagement required here to work on this would be the domestic trade and consumer affairs, housing and local governments, and the city councils. We also have a domain for food trade and investment. Trade agreements need to align to population nutrition health agenda to minimize the negative impacts, that is the control of unhealthy food and beverage imports, and maximize the positive impacts, the opposite side, reduce tax tariffs on healthy foods. Now, food trade and investment policies definitely need to align with NPAM3, WHO nutrient profiling system, and the SDGs. The multi-sectoral engagement required will be the International Trade and Industry, the Prime Minister's Department, Ministry of Health, and Finance. The AOR strategy is to discourage access to cheap, unhealthy foods, discourage purchase of sugary foods and beverages. Now we move from the public sector to looking at public-private partnerships, or PPP. Now the Montevideo Roadmap essentially establish rules and contributions of PPPs in combating obesity and NCDs, and we recognize that the scaling up nutrition initiatives to tackle malnutrition have been very, very impactful, especially across Asia. Now, the 11th Malaysia Plan, 2016 to 2020, through the strategy of improving well-being for all, in fact, encouraged PPP involvement in health. Now, and food industry partnership, partnering government to support the SDGs, essentially encouraged through the corporate social responsibility activities, the CSRs. Now, food corporations in public health lead to increased risk for conflict of interest. That is also very clear there, especially through the commercial determinants of health, CDH, corporate political activity, CPA, corporate social responsibility, CSR. So we need to ask, would PPPs or could PPPs work with regards to AOR? And we say yes. When we look at two areas, nutrition labeling, the first, we applied the Business Impact Assessment BIA Obesity tool to look at this, and the recommendations were industry needs to commit to long-term goals for achieving public health goals for obesity reduction prevention. There need to be mechanisms to control commercial determinants of health. There need to be a publicly available disclosure on corporate political activities. Now, positive PPP engagement relates to compliance to nutrient targets consistent with WHO nutrient profiling systems and MOH direction, participate in the front of package labeling and the MyFCD programs. Further, nutrition claims for healthier products that are generated by the food industry need to follow the Healthy Choice logo and or criteria. Now, the AOR strategy here is reformulate for less calories, less sugar, less fat products. The second aspect, promotion practices, recommendations to industry are to set mandatory governance with monitoring for promotion in all settings, including in-store, online, schools, and playgrounds. Guidelines for rewards programs should be set, disallow CSR activities linking to strong branding on product promotions, encourage promotion of healthier products aligned to the WHO nutrient profiling systems. Positive PPP engagement would be responsible marketing policies for all children's settings. These should be applicable to children up to 18 years of age. Time-based restriction of unhealthy food advertising on children's TV channels need to be introduced, except children's or adhered to, except children's audience viewership. Now, is there any problem? I seem to have lost the I seem to have lost my presentation.
Yeah, it's not showing here. Prof, can you reshare again? Can you stop sharing and reshare?
Yeah. I don't know why. Okay. Okay, fine.
Yeah, okay, now.
Okay. So time-based restriction of unhealthy food advertising on children's TV channels should be introduced and adhered to accept that children's audience viewership should drop to 15 to 25% instead of higher percentages, and applying or adherence to the WHO nutrient profiling systems when considering what constitutes unhealthy or healthy advertising. So essentially, the AOR strategy is to remove unhealthy food marketing to children of all ages. Now, coming to product accessibility, the recommendations are to control CDH linked to ultra-processed foods and beverages which are high in fat, sodium, and sugar. This would be to increase availability of healthier food products according to the WHO nutrient profiling. That would be a positive engagement. As per corporate strategy, to encourage a portfolio of healthy food and beverage product developments to target at least 25% or more of the core business of the company. A positive engagement would be reference national and international recommendations, the WHO SDGs to set companies' nutrition targets and plans. And for product formulation, this is the big ticket item. Reformulate ultra-processed foods products as per sugar, fat, and or sodium criteria to meet WHO nutrient profile models. Formulate the other side, formulate healthy food and beverage products to at least 25% or more of the core business of the company. And for SMEs, request government assistance or provide government assistance to reformulate unhealthy food and beverages. So each of these have positive PPP engagements. A reformulation or reduction of portion sizes of products should be aligned with HCL, the Healthy Choice logo, and the Whole Nutrient profiling model. The introduction of healthy food and beverages in a company's portfolio is an extremely positive engagement. And as regards SMEs, there's a requirement, or rather there would be a need to build capacity and skills. And that would require the support of the Ministry of Rural Development and Finance. So the AOR strategy would be to increase availability of food and beverages with less calories, less sugar, and less fat. Now let's move to the economic activities of government. We move to a different area. Now, the fiscal policies of government, the biggest in this area relates, as everyone knows, to the excise duty of 40 cents per liter on sugar-sweetened beverages that was introduced in 2019. And as applied to a 250 ml volume of SSB, that would be about 10 cents. Now, when applied to the various SSB categories for non-alcoholic beverage sugars, this would be if exceeding 5 grams per 100 ml, for milk-based sweet drinks exceeding 7 grams per 100 ml, and for fruit and vegetable juices if exceeding 12 grams per 100 ml. Now, this is in terms of looking at total sugar content, whether naturally recurring or added. Now, taxing SSBs would ideally work towards reducing sugar intake of the public. However, the real picture is that Malaysia ranked 10th of 161 nations for sugar consumption per capita, despite the sugar tax of 2019, that's the OECD FAO data of 2021. The annual per capita sugar consumption was assessed to be about 58 kilograms and projected to go up to 61 kilograms by 2030. Now, a systematic review on empirical data shows that low tax rates did not significantly impact weight outcomes. With price elasticity modeling, looking just at SSBs, supporting raising prices by 20% would reduce SSB consumption by 24%. That's the hard number. A Monte Carlo simulation study in Vietnam found that a 5% price tax had little impact on weight loss, but when going to 20%, substantially impacted overweight and obesity rates by about 12% reduction, 12.7, 12.4%. Now, this is assumed to predicted to save about 27 million US dollars as per direct medical cost in Vietnam. So looking at just the sugar tax. Now, that evolutionary steps have been going on since 2014. It was been on I would say, a low fire tax proposal involved intersectoral collaboration with the Health, Royal Customs, Department Finance, the International Trade and Industry. In May 2018, Malaysia was leading ASEAN for establishing a framework for introducing fiscal measures for SSBs with UNICEF and WHO guidance. By July 2019, we saw the 40 cents per liter story for two categories, and by January 2023, this was extended to premix preparations. And more recently, the November budget presented in 2023 announced a tax increase of from 40 to 50 cents per liter. But is this enough to, or rather adequate to achieve the AOR goal? Well, tax rates falling below 20% will not impact weight outcomes significantly. At least $1 per liter tax rate would be in line with international benchmarks and the available evidence on the effectiveness of SSB taxes. The other side is we need to acknowledge that sugar intake is excessive in Malaysians, and we also have to worry that the SSB intake patterns in adolescents is growing. So the AOR strategy is government should aim for a flat 20% SSB price tax, the imposing of this. Now, going to look at another aspect, enabling healthy food access. Now, the Ministry of Agriculture and Food Security recognizes one issue of food security in Malaysia is the rising childhood obesity trend. That's on their radar. Now, in collaboration with the Ministry of Domestic Trade and Consumer Affairs and the Ministry of Agriculture and Food Industry, two clusters relating to healthy food access have been covered, the accessibility cluster and the availability cluster. The accessibility cluster is we are looking at the obtaining of healthy, safe food that is required, and availability cluster directly looks at the food supply situation. How would accessibility and availability work? Well, subsidies related to food securities are quantified by financial aid in two areas, directly to industry and farmers to offset the cost of food production, and giving to consumers directly to enable access to low-cost food for low-income households. The reality is food subsidies direct to consumers, all consumers irrespective of the B40 households, are typically for sugar, flour, rice, and cooking oil. And there is price control, and that governs rice, chicken, eggs, and milk. We also have the cashless subsidy through Sumbangan Asas Rama, with the Bakul Rama originally about 100 ringgit per month for 6 months, but now it's been up to 1,200 ringgit for the B40 households. Now, covering rice, condensed milk, rice vermicelli, and egg. You also have the Menu Rama. The question is, do subsidies, price control, and schemes benefit AOR when we are relating to enabling access to healthy food? Well, let's examine each of these items. Sugar, definitely no. Is this a healthy food? No. Price control has been in place since 1961. The recommendation is abolition of price control for sugar is required. Instead, consider limited food stamps for the B40 groups. In fact, the Prime Minister has talked about channeling sugar subsidies, to review the sugar subsidies, saying that the money should be channeled into the health projects. What about cooking oil? Is this a healthy food? No, when we consider that the favorite of Malaysians is to go for uh, high consumption of products using lots of oil like fried foods. The subsidy has reached up to 1.9 billion. The recommendation is abolition of price control for cooking oil is required. Instead, provide limited food stamps for the B40 groups. What about poultry and eggs? Is this healthy food? Yes. It began in 2022, stopped in November 2023 because it costs the government up to 3.8 billion. The recommendation is consider subsidies for B40 households to cover this. Wheat flour, this is not a healthy food. Abolition of price control is for refined wheat flour is required. Limited food stamps should be considered for B40 households. But on the other hand, subsidies of whole wheat flour should be encouraged to replace the subsidy for refined flour for the B40 group. What about the SARA scheme? It stands at high risk as a source of ultra-processed foods. Instead, consider food stamps to differentiate for the essential food items, fruit and vegetables, dairy, eggs, and rice. For AR strategy, subsidize B40 with food stamps specific to healthy foods, vegetables, fruit, chicken, fish, whole grain bread or flour, abolish price controls for sugar and cooking oils. Now let's look at policies and programs influencing the obesogenic environment. Now we have looked at, I have covered, the one big area is marketing and advertising of unhealthy foods to children. The first aspect, policy initiative of government, the guideline on advertising and nutrition information labeling of fast food was introduced in 2008 by the BKKM. Is this enough to meet the agenda of obesity reduction? No, because this is only a voluntary status in terms of regulation. Further, the age limit is insufficient to reduce exposure in adolescents. The recommendations are to change the policy to mandatory status, apply it to all media platforms, and it needs to be extended to children up to 18 years old. Fast food advertising on TV should be restricted even during family programs or not permitted to be advertised at all. The AOR strategy is to remove unhealthy food marketing and advertising to children of all ages. Now, another policy initiative, responsible advertising to children, pledge or the Malaysia pledge in short. Now, this comes from the Malaysia food and beverage industry. Is this enough to meet AOR? Definitely no, because it's a voluntary status. Further, the age limit is insufficient to reduce exposure in adolescents. Recommendations is the policy should be adopted as a mandatory status and applied to all media platforms. Again, to consider restricting advertising during peak viewing time, application of PVT should be 15 to 25% of audience viewership. There's a need to apply the WHO nutrient profiling system for criteria to decide what is permitted or non-permitted foods in terms of advertising. Time-based restriction on children's programming hours need to be considered, and also incentivize advertising of healthier permitted foods, that is going as seen in China. Now, the AOR strategy is to remove unhealthy food marketing and advertising to children of all ages. Now, let's move to nutrition labeling and the front-on package nutrition labeling. Now, most systematic reviews are there to indicate that nutrition labeling and interpretative labels are effective in strengthening consumers to pick the right nutritious food. However, the adoption accuracy and compliance can have issues. Now, the Nutrition Information Panel is a very, very important tool if we are looking at reducing the incidence of obesity and NCDs. The NIP has received a great deal of support through the NCD Action Plan as well as the Malaysian Dietary Guidelines 2020 forms in terms of the need to promote this. Now, mandatory disclosure on the NIP aspects of packaged food has a great potential to influence food manufacturing as well as retailers, move them towards reformulation. Now, NIPs are clear in terms of declaring for energy, carbohydrate, protein, fat, and sodium for all prepackaged foods and beverages and for total sugars. But they failed to separate added sugar in this list. This is a missing item that actually is very critical. Now, there have been discussions in terms of interpretative labels. There are challenges to this, as seen in the UK. I'm not going to talk about this because it leads to a lot of discussion. But let me focus on NIP, Nutrition Information Panel. Now, the Food Appy rating, which assessed this aspect of government, ranked it as medium in implementation, indicating that, in fact, this received the highest scores amongst all the food environment policies by experts, specifically covering the ingredient list and nutrient declarations and the regulatory systems for health and nutrition claims. When looked at from the other side, the business impact assessment obesity evaluation, it was seen that 30 out of 33 companies were disclosing commitments related to nutrition labeling, with some companies scoring very highly for published information, 16 out of 33 companies. Further, almost half of these companies included total or added sugars, 13 out of 38, or trans fat, 13 out of 24 content. So in terms of nutrition claims, when you looked at the Food Appy rating, food labeling was fairly comprehensive and almost in line with international standards. The overall recommendations are to provide for declarations of added sugars in food and beverage products. This is because total sugars, berries, added sugars, it gives a total of added sugars and natural sugars, which consumers will not gauge. So there's added sugars are what we need consumers to limit. And further, there should be a move to comprehensive nutrition labeling online and on pack, as well as in terms of the quantitative ingredient declarations. Encourage industry to participate in government-led initiatives for the Malaysian Food Composition Database. That's another recommendation. Further, allow only healthy products to carry the nutrition claims as opposed to the unhealthy products. Encourage quick service retail and retailer sectors to display the nutrition information using the right font size on price tags, as similar to the price tags on the menu board for all takeaways or ready-to-eat foods. So essentially, for the strategy for AOR as regards nutrition labeling is to inform the consumer for less calories, less added sugar, and less fat. The other aspects in terms of the front of pack nutrition labeling, well, as regards the energy icon, experts are looking at the Food Appy rating, application to the menu board labeling at quick service, the QSR sector, as low implementation. So FOPLs are poorly, the uptake of FOPL is very low in restaurants. For BIA obesity evaluation, 17 out of 28 food companies were displaying the energy icon on the FOP labeling. So that's less than half, or almost similar to half. The recommendation is to encourage industry, both the food industry as well as restaurants, the services, to participate in the FOPL programs. What about the Healthy Choice logo? Well, as regards the food sector, only half of the companies were using HTL or opting for their own FOP formats, 14 out of 28. The recommendation is that at least 25% or more products should be termed as healthy to carry the HCL logo. That means reformulation of products is called for to earn the HCL logo. The AOR strategy is to inform consumers for less calories, less added sugar, and less fat. Now, another program that needs to be highlighted is the Malaysian Healthy Plate, the Suku Suku Separuh aspect. Now, the Malaysian Healthy Plate was launched in 2017 by the Ministry of Health with the SSP, the Suku Suku Separuh moniker. It represents a balanced meal with healthier food choices, fruits and vegetables occupying half a plate, grains, preferably whole grain, protein-based food about quarter plate, and to drink plain water instead of sweetened drinks. Portion control and adopting low-fat food preparation techniques are the desired behavior changes. And this, in fact, is a key recommendation to adopted for key message 1 of the MDG 2020 for a single meal. Now, the uptake of SSP according to the NHMS 2019 data set analysis is that there's a poor awareness amongst the public, that it is expensive for the low-income groups. Only people who are sick pay attention. Yet some preliminary data is indicating that the SSP concept understanding promotes adequacy of the food and vegetable intake. And this adequacy intake by obese individuals in particular can lead to significant BMI reduction. Although the study is small, that is a positive outcome shown. So looking at the Malaysia Healthy Plate in terms of the public uptake from NHMS 2019, the indicators are very clearly lack of awareness in the majority. Despite awareness, income, age, and gender are influencing its poor uptake, and achieving adequacy of intake of fruit and vegetables can lead towards reducing obesity. The recommendation is that policymakers, healthcare professionals, and nutrition educators need to engage collaboratively in promoting the SSP concept. Integration of the SSP into public health education and promotional programs should be long-term and should be coordinated, consistent, and sustainable. In talking about implementation, the indicators should be aimed towards target groups and outcomes, that is participant data. SSP adequacy should be SMART, specific, measurable, achievable, relevant, and time-bound for across all age groups, support cultural diversity centered at the community level and in workplace settings, hawker outlets, and universities. That's in regards implementation. For chronic disease management, the indicator is BMI reduction. So access to counseling programs incorporating the SSP at outpatient settings or weight loss should be there and tied in with outcomes related to weight loss or adequacy of achievement for the SSSP. So this should be SMART. Affordability and access, the indicators should come through population nutrition surveys. So the government should consider subsidy stamps for B40 households to achieve the adequacy quota for fruit and vegetables. So the AOR strategy is to promote SSP through smart outcome-based programs, increase access and affordability of food and vegetables. Now let's move to the second aspect, moving from diet to the physical environment and activity. Now, government capacity to effectively combat obesity is through promoting physical activity in various settings via strategic policy frameworks, public education campaigns, and collaboration. Now, you have exemplars coming from Finland, Netherlands, and Denmark. Closer to home, you have Singapore. I'm not going to go into the details, but multi-sectoral participation is evident in Malaysia. It's very critical for successful adoption of sustaining a good physical environment to promote physical activity. Now, the policies, unfortunately, the policy options to combat obesity in Malaysia, which originally dealt with or rather accommodated physical activities, has what you call dropped it from the newer version, the reviewed nutrition policy options to combat obesity in Malaysia. So the recommendation is to ensure the revised nutrition POCO includes physical activity. Now, the National Plan of Action for Nutrition of Malaysia emphasizes promotion of healthy eating and active living. So it combines diet and physical activity as enabling strategies. The National Physical Activity Guidelines acts through health promotion. And what about NASPAL, National Strategy Plan for Active Living? Focuses on promotion and education, partnership and collaboration, capacity building to encourage the public to be more active. Now, what we see is multi-sectoral collaborations and PPPs are needed for implementation of suggested programs and policies. These programs need to extend beyond urban settings to reach rural communities. The policy options need to be changed to a mandatory status and using smart outcomes linked to weight status to measure implementation outcomes. So the target for a strategy is target healthy BMI status for population. Now, another aspect, looking at multi-sectoral policies promoting physical activity, coming through the Ministry of Education, which focuses on school-based surveillance, monitoring prevalence. The recommendation is to introduce intervention programs for overweight or obese children, as well as school-based programs to increase physical activities and wellness of school children through exercise, sports, and education. The implementation outcomes, weight status should be tied to SMART aspects for measuring. So the AOR strategy is to target healthy BMI status for population. Now, looking at stakeholder ministries and city councils covering the Ministry of Urban, Wellbeing, Housing, and Local Government and local authorities, the indicators for promoting physical activity is essentially urban planning for an active population health and wellness. The recommendation is implementation outcomes. The use of green space by the public extra can be measured using SMART outcomes. So the strategy again is the same, target healthy BMI status for population. Ministry of Finance, which offers tax reliefs for the purchase of sports equipment to encourage sports and exercise. Again, the implementation outcome should be SMART tied into equipment purchase. So the strategy is to target healthy BMI status for population. So what about programs for promoting physical activities? You have several: Fit Malaysia, Hari Sukan, Wellness Hub, and you see the outreach for these. The scopes are different, but the recommendation for all these are essentially that implementation outcomes should be tied to being SMART, looking at the frequency of participation. For Hari Sukan, a dedicated program needs to be provided and at the community level, similarly with the Wellness Hub. Again, similar, aiming for BMI status. The other programs, COSPEN, Community Sihat Pembina Negara, the Young Doctor Club program, Siswa Sihat, the X-Break, all these, the implementation outcomes need to be measured. That is the participant data. How many are participating? Are they coming back? These should be linked to being SMART. The overall agenda is to achieve or rather target a healthy BMI status. So let's move to monitoring and surveillance.
Hi, Prof. Sorry. Prof,
Yeah,
you could wrap it up because we are.
yeah. So I'll move here. Essentially, our country is doing a lot of surveys, the National Health and Morbidity Surveys, men's survey here. In essence, the monitoring indicators are pointing out to the rise in obesity in the young and a high consumption of sugar-sweetened beverages and a low consumption of fruit and vegetable intake. Essentially, recommendations should be to provide health intervention for the obese that comes in with monitoring and surveillance, and to ensure that MANS should be conducted once in 5 years, and to provide capacity building of enumerators, that is the survey implementers, to ensure quality survey data collection is provided. The overall aspect in monitoring and surveillance is to aim for a healthy BMI status and to aim for a timely and quality data collection to enable identifying nutrition goals for intervention. Now, another aspect, the Global School-Based Student Health Survey, which is more or less targeting which has picked up a low intake of fruit and vegetables and SSBs and fast foods amongst school students. Recommendation is that healthy food education and promotion needs to be the follow-up aspects. And then adolescent surveys, the same problems. Again, healthy food education and promotion is required. Similar healthy BMI status should be aimed for. Quality and timely data collection is needed. We also have the school guidelines on healthy food intake in schools. Recommendation is the involvement or collaboration between Ministry of Health and Ministry of Education. Okay. We also have that essentially access and affordability of healthy foods and beverages to school children is very critical. We also have the outside schools, a prohibition of selling foods and drinks. Again, the recommendation is that local school authority council need to ensure continuous monitoring that is low. Also to look at food canteen operators should not be selling prohibited unhealthy foods, and tying these with implementation outcomes, unhealthy food sales linked to SMART. So overall aspect of this is to discourage sale of unhealthy food and beverages to school children. So moving to equity and inclusivity, I'm not going to tackle this, but the key question is that the agenda for obesity reduction should cover socioeconomic inequalities, and these can be addressed through addressing equity, which requires multi-sectoral collaboration, access to health services, health, food, and physical activity, inform for planning effective interventions in the vulnerable subgroups, because of the socioeconomic inequalities are highly linked to overweight and obesity, improving healthy food access through food subsidies. So similar to all the others that we talked about, multi-agency collaboration is required in order to ensure that AOR programs are equitable. Inclusivity is the same. To be equitable and inclusive, multi-sectoral collaboration is very critical. So with that, the mapping of the areas of strategies that we have covered, multi-sectoral collaboration, intersectoral partnerships, civil society participation, trade and foreign direct investment, fiscal policies, subsidies, price control, fast food marketing, food advertising, the nutrition information panel, the front-on package nutrition label, the Malaysian healthy plate, food systems, production and distribution, physical activities, policies and programs, monitoring and evaluation. We have actually linked these to very clear strategies that should be achieved, or the recommended strategies for the agenda for obesity reduction. less production of high-fat, sodium, sugar products, reduction of BMI, unhealthy food marketing to children reduction, decreased sugar intake, fruit and vegetable excess and affordability, unhealthy food excess should be cut, promotion, unhealthy food advertising needs to be controlled, using smart outcomes to directly link to whether programs and policies and strategies are working, regulating quality, data collection, inclusivity, and equity. Now, I'd like to end by thanking all my co-authors in this chapter. We have Prof. Ismail, Dr. Geeta, Dr. Hazizi, Encik Nazli, Dr. Hazrin, Fauzi is there, Dr. Sam, and Puan Fatima. Thank you.
Thank you, Prof. I know
I apologize for the excess time taken.
no problem, no problem. I know it's understandable. It's it's very comprehensive, review of whatever strategies that we have so far, how we can improvise from there. So understandable that it takes more time. That's fine. But because we have to really move on to the next speakers, there will be no Q&A session. But if you have any questions, participants here, you can contact Prof. Tila directly, or you can also contact one of us in Maso. We can then direct the questions to Prof for further clarification and so on. So with that, thank you so much, Prof. Yes,
please charge your questions through the chat. I'll answer directly.
Yeah, Prof will be here for
yeah.
Okay.
Yeah.
So, please chat. You can type in your questions, and she's happy to take it from there. Thank you, Prof, once again for a very comprehensive presentation on the strategies part. Okay, so moving on to the next speaker, we have Professor Pobi Koon. Prof, are you here? You can see your name. Yes. Hello. Hi, Prof.
Hi, I'm here.
All right. So, Prof, before you start, let me just introduce you. I guess there's no need to introduce you. A lot of people know you, but I still need to do my job as a moderator. Okay, so Professor Pobi Koon is a professor of nutrition in Faculty of Health Sciences, University Kebangsaan Malaysia, UKM. She has more than 20 years of research experience, that involves multidisciplinary and multi-country projects, research area focus on childhood and adolescent nutrition. So she's going to talk about youth today, and projects cover surveys, observation, and intervention studies. She has led many international funded studies, including those from UK Medical Research Council, United Nations International Atomic Energy Agency, and also IDRC, International Development Research Center in Canada, and Glutamate Technical Committee, International Glutamate Technical Committee, as well as some of them from industry, and she's also the PI, the principal investigator of CNAT's Southeast Asian Nutrition Surveys. She has done 2 series of the surveys so far, it's a nationally representative survey on nutritional status of our children, nutrition in Malaysia, and also toy box study, in Malaysia. It was an intervention study looking at how we can reduce obesity rates through improving the preschoolers' healthy eating and physical activity levels. So there's so many, and she has been a very instrumental as well person that has been given a lot of contributions in the consultation work for Ministry of Health and other institutions such as Academy of Sciences Malaysia as well, ASM. So she is now the editor-in-chief Malaysian Journal of Nutrition. So be nice to her, because she decides, our paper, those who in the nutrition field who are sending your journals or papers to Journal of Nutrition, Malaysian Journal of Nutrition. Okay, so and she's a fellow of Nutrition Society of Malaysia and life member of Malaysian Association for the Study of Obesity. In fact, she was in the Masuk Council member for many, many years before. Yeah, Prof. So, Prof, you will be talking about youth today. Yeah, from classroom education to community perspective. So, over to you, Prof.
Okay, I'm sharing my slide. Can you see my slide?
Not
Not
yet.
yet.
Not yet.
Okay.
It's loading. Yes,
Now?
now we can see.
Now,
Yeah,
yes?
you can put in slide mode. Yes.
Yep.
Yes. Okay. Now.
Okay, it's working?
Yes.
All
It's,
right.
yeah, we can see. Thank you.
Thanks, Geeta. So, very good afternoon, everyone. So, about being editor of MJN, being nice to me is not going to help you because all papers are peer-reviewed, yeah.
Yeah,
So,
joking only lah, Prof.
yeah, I know.
I know you go
All
through the.
right. Thanks. All right. So for today, for Obesity Week Malaysia, I'm going to share with you a little bit of my research. Some of you may have heard this before and it may get boring for you, but I'm putting it all together into one sort of quite a long story. So from classroom to the community, how we can empower Malaysian youth through nutrition education. Okay. Okay, so this is the outline of my presentation. We will start by looking at a little bit of the current nutrition issues in Malaysia. Then we're going to look at nutrition education programs, and we'll look at from preschoolers all the way to secondary school, various projects that I've been involved with. And then we are going to look at a slightly bigger picture than just nutrition education programs. So in terms of childhood obesity in Malaysia, this slide is sharing with you data from the NHMS 2019, and it's for children aged below 5 years old. And as you can see here at the top right-hand side, overweight and obesity in children was only 5.6% amongst those below 5 years. And it's happening more in urban areas and among the ethnicities, highest in the other ethnicities apart from all those listed here. And then second highest among the Indians, and then third amongst Bumiputra Sarawak. Now this is for below 5. So the next slide shows you for children who are aged 5 to 17 years old, and for overweight, is about 15%, and obesity is another almost 15%. Again, in terms of area of residence, the prevalence is higher in urban area. Now, for ethnicity, for 5 to 17 years old, the highest prevalence now is among the Indians, but as you can see, it's not very much difference with all the other ethnic groups as well. It's almost everyone is at 30% or so. So not that much difference in terms of ethnicity. Now going on just a little bit about adults. So we know children go into adults. So what's happening among adults in Malaysia? This data is from the same survey, NHMS 2019. And at the bottom right-hand side, you can see the prevalence of obesity among adults aged 18 years and above. This is only for obesity, yeah? We did not add in the prevalence of overweight here. Otherwise, it'll be even more. So prevalence of obesity here, you can see is a third of Malaysian adults are obese. In terms of various states, so Putrajaya wins hands down 45.8%, followed by Perlis at above 40% as well. But the rest of the states are not far behind. We are all at almost a third of the population being obese. So we really need to think about what do we want to do with this issue. Okay, now before I share with you what we did for obesity interventions, I'll share with you a little bit about CNUTS. So CNUTS, as Geeta mentioned just now, we've conducted it for 2 rounds. The first round, about 10 years before the second round. So that was data collection was conducted 2010, 2011. And for CNUTS 2, data collection was conducted 2019 and 2020. And the CNUTS actually was conducted in 4 countries in Southeast Asia. But today I'm sharing with you only just a little bit of results from CNUTS Malaysia. All right, so the latest CNUTS results has been published recently, just online first. Until today, it hasn't yet been published properly, like not formatted yet, but you can get the paper online in Public Health Nutrition, and you'll be able to see the prevalence of overweight, obesity, undernutrition, and so on. But on this slide, I highlight to you just a little bit about the dietary intake. So in terms of dietary intake, there's low calcium intake and low vitamin D intake. And this is the same finding as we found in CNUTS 1. In terms of blood biochemistry, when we took blood to look at prevalence of anemia or iron deficiency, vitamin A deficiency, or vitamin D deficiency, the prevalences are lower compared to CNUTS 1. So things seems to have improved in terms of micronutrient deficiencies, but only just slightly, except for vitamin D, where the prevalence was halved. Right. Again, we go back to thinness, overweight, and obesity. So this slide is sharing with you a comparison between the pink colored ones are CNUTS 1 results. The orange colored ones are NHMS and 2019, and then the blue colored ones are CNUTS 2. Okay. So looking at the data, it appears that NHMS seems to have the highest prevalence of thinness, overweight, and obesity. But I must warn you that CNUTS 2 data was only representing for Peninsular Malaysia. And that's because COVID happened. We finished data collection in Peninsular Malaysia, and then before we could move on to Sabah and Sarawak, which was already in the plans, COVID happened, and our movement control happened for a very long time. So data collection in Sabah and Sarawak was scraped, and therefore the data for CNUTS 2 is only representative of Peninsular Malaysia. So yeah, you can see there are differences, but obviously you can see here that overweight and obesity prevalences, no matter which of these survey, is higher than thinness. Okay. This one gives you a breakdown to explain why NHMS data might be much higher in terms of overweight and obesity. And you can see that this is from CNUTS, but you can see that prevalence of overweight and obesity is actually higher for the older children. And because the NHMS data presents for 5 to 17 years old, therefore, we would expect that prevalence of overweight and obesity amongst these older children compared to CNUTS age range of 5 to 12 years old will be higher, right? But again, here you can see prevalence of overweight and obesity is higher than undernutrition. So if we want to tackle the obesity problem, we need to know what we can change and what we cannot change. And this chart, which is drawn by 2 of my postgrad students long ago when they were with me in UKM, on the left-hand side, some unmodifiable factors, such as intrauterine factors or genetics or the interactions between these two. And on the right-hand side are the modifiable factors. And the ones that we always talk about is physical activity and diet. But it's not just that. If you think about sleep, getting enough sleep can help you to prevent overweight or obesity as well. Okay. And basically making good lifestyle changes can help us. Now, if we want to do interventions, I have shared this slide before and I like to share it again. It's not a new slide. It's not even a new paper. It's from 2014. That's 10 years from before. But it tells a story that I think all of us who intend to work with intervention should think about. So for example, if we look at this red line that's called high risk trajectory, most of us attending this talk today would be somewhere in the adult age group. And if we start screening at the adult age group, it might be too late to reduce risk. So if you look at the bottom of the slide, there's this green part called plasticity and the red side called detrimental effects of lifestyle changes and increasing mismatch. So even if we do interventions when we are adult, we can reduce NCD risk, but only slightly. So you can see the red dotted lines went down slowly if we do intervention at the adult age group. If we start a little bit earlier when they were children or adolescents, the high risk trajectory can change to maybe moderate risk trajectory, the orange line. But the best would be to start early during pregnancy and infancy so that we can prevent individuals from going on the high risk trajectory for NCDs and they can stay at low risk trajectory for NCDs. So basically what this slide is saying is if we want to do interventions, it's always good to start as early as possible. Now, this one shares with you some of the plans that Ministry of Health has put in place. The National Plan of Action for Nutrition Malaysia. We are at 2024, so it's about time that a review for NPAN is done and maybe planning for NPAN 4 should be ongoing soon, if not currently yet, right? So we set the targets 10 years back to reduce underweight, stunting for children below 5 years old, trying to reduce thinness basically for all age groups, including overweight and obesity. But I think overweight and obesity targets might be to stay put and not to increase anymore the percentages. But in terms of policies and programs, I think Ministry of Health has put in place many enabling strategies that if it's done correctly, it will definitely help Malaysia as a nation to improve, including, so for example, promoting maternal and infant young child nutrition. So that's starting early, that's good. Promotion of healthy eating, controlling of nutrition deficiencies and NCDs and so on, which are all good. But some of these strategies might not be working at the best of in the best way, and therefore we are still seeing a lot of diseases amongst our population. Obesity is still on the rise, diabetes is prevalent, and so on. And you heard Prof. Ila just now presenting about strategies for the prevention of obesity Malaysia, which is initiated by MASO, but with a lot of support from the Ministry of Health as well. So hopefully, looking at all these big picture strategies, and if we can implement them properly, it will run and make our population more healthy. But so this looking at some of the programs that has been around to tackle on this right-hand side, overweight and obesity. I have the prerogative to listen to Encik Nazli a couple of days ago talking about sugar subsidy removal and also the sugar sweetened beverages, lowering of sugar levels in the drinks. And it seems to be working well. So that's a good thing that is happening in our nation. And apart from that, I think there are various programs. The MyBFF programs, Body Fit and Fabulous, was conducted by Ministry of Health at various levels, school, home, and at work. I'm not sure whether it's still ongoing. I think it has stopped. And so to these programs below, Ceria is by us in UKM, Juara Sehat also by us in UKM, and Toy Box Study Malaysia. All these projects has ended. Toy Box Malaysia is also at nearing the end of our grant. Yeah. So today I will share with you 3 programs that we have conducted in UKM. I'm going to start with Cergas because this is one of the target group that we started with, which is adolescents. So Cergas intervention targets Form 1 and Form 2 secondary school children, and we call it Cergas because it stands for Ceria, Respect, Gigih, Aktif, dan Sihat. But it is also representing what we are doing with the children, which is to try to improve the children's fitness. So the program was for 12 weeks, and I'm going to show this chart to you. Let's start from the right-hand side where you can see the green box at the top called CG. These are our control schools, children at our control schools. All they get at school is the normal PE lessons following the school curriculum. Now, the other group is called Intervention Group 2, and Intervention Group 2 is also getting the same PE lessons in school, but we bring this IG2 group for a 2-day educational camp, and I'll show you what we did with them in this 2-day educational camp. Okay, now the IG group 1, we actually have both the school curriculum thing as well as the 2-day camp. And in addition to these 2 things, we do actually every week, twice a week, and each time 1.5 hours of sessions with a trained fitness instructor doing aerobics and resistance exercise training for 1.5 hours for 12 weeks. Okay. Now, before and after these interventions were done, we had baseline measurements and post 1, post 2, and post 3 measurements. So post 1 would be at week 12 at the end of the intervention, and then 12 weeks later and another 12 weeks later to look at changes in body composition and anthropometry. I'm going to show you what we did with these children in the camp. So this is exercise training and education sessions based on the modules that we have. They have group discussions, we have demonstrations, we made games for them, so it's more interesting, less boring, and we have also aerobic exercise. This is just one of the group pictures that we took of the team. Right, so this is some findings very briefly from Cergas. The dotted blue lines are the IG1 groups that also had the weekly exercise sessions, and you can see that among the green line, which is the control group, and the red line who had that 2-day education camp, there is not that much difference. It's going up and down and it's about the same. But for the blue lines, the ones who actually have twice a week physical exercise in school, it seems to be working, and it's helping them to reduce their waist circumference and body fat. In terms of BMI, in the beginning, not so clear, but you can also see that over the next time point, it's also reduced. However, we couldn't get any statistical difference for this BMI. Okay, so generally, our conclusion from Cergas is that it's important to have the weekly exercise in order to see these changes in body composition and weight. Okay, just attending class for 2 full days, learning all about good nutrition, learning how to exercise and so on is not enough for us to see any changes in these adolescents. Right, then we move on to Juara Sehat. Juara Sehat is an intervention program that we did with primary school children. For this project, we actually targeted only overweight and obese children. So there were no normal weight children involved in Juara Sehat. And it was also a 12-week program for those children who are from primary 3 to primary 5. And we did this in KL. There's a control group who didn't get any of these activities with us. So what were the components that we were looking at? We wanted to modify their dietary diets, physical activity. We had classroom activities as well. to teach them about healthy eating and healthy lifestyles. And we also involve the Parents Teachers Association. So this is a good thing about Juara Sehat, where if you involve parents and teachers as well, it's more likely to have an effect on the children. Okay, so the modules, we also had modules for children and facilitators. Both modules reflect the same 6 topics, which is about am I healthy, teaching them about growth charts and so on, about cheerful and healthy chef, how to prepare healthy foods, about how to choose wisely, about active physical activity, as well as fruits and vegetables. So these are some of the pictures that we took during the intervention. We had activities for the children, but as you can see here, we also have involvement of parents. So we have a healthy lifestyle forum for the parents and teachers as well. These were the modules. So on a weekly basis, I think every 2 weeks we went and we teach the children each of the module. In week 5, it was about physical activity. So we had some outdoor activities for physical activity. Apart from just teaching them the module, we also had fun activities for the children. So we had a senam aerobic competition. We had mini chef competition where children actually worked with their mother to prepare food, and we gave prizes for those who did the best. But we also had this invited chef, I forgot his name now. His name starts with an M. Yeah, who helped us to do a demonstration to the parents who were there as well. And on the same day as this cooking demonstration, we had a fun run challenge for the children. So this is a flow of activities and evaluation. We, similar to Cherigas, you can see we do pre-test and post-test, okay? And in between that, we did the healthy lifestyle seminar, we did the 6 modules of intervention, and finally, we had all these fun activities towards the end of the program. So just a very quick sharing of the results. This first slide shows you changes in BMI, waist circumference, and body fat. And we did have a control school. So the lighter blue line is for control and the darker blue line is for intervention. So the BMI Z-score for the intervention school started out earlier, but you can see a mini drop in BMI Z-score in the intervention school, whereas for the control school, the BMI for HZ score actually increased, okay? And so on. I'm not going to tell you in detail for the rest of them. But when we look at between group differences, all of them are significantly different, okay, between the intervention school and the control school. In terms of knowledge, attitude, and practice, because we taught them lessons, so we also can see that knowledge actually improved in the intervention school. So did attitude and practice. But you can see that at 24 weeks after 12 weeks after intervention, so at week 24, practice scores and even attitude and knowledge scores has dropped. Okay. In terms of dietary intake, there were no significant differences between different groups, but for energy intake, there is a significant difference between intervention and control groups. Okay. And in terms of physical activity, also we couldn't find any significant differences between the 2 groups. But although the intervention school actually have higher physical activity, they did have that from the start, and the intervention school also had increase in physical activity as well. Okay. So what did we find from Juara Sehat program? We found that there were significant improvements in anthropometric status as well as KAP scores among overweight and obese children. And there is a good likelihood of improving their KAP scores when you do such intervention with primary school children, though we have to keep in mind that after a while, they may forget what they have learned, which means that in school, teachers should keep reiterating what the children have learned so that they don't forget. Okay. However, for dietary intake and physical activity, there were no differences. Now, when we do intervention, we don't want the intervention to end with the project because we do this as a program where we go to the school and then we go home and then that's it, everybody forgets. But what we want to look at also is the sustainability of the program. So for Juara Sehat, we actually went back to the school about 1 to 1.5 years later, and we interviewed various people, including the children, the headmaster, as well as the teachers, and I think some parents as well. And this was what we found. The factors that can facilitate sustainability of interventions, such as those we did in Juara Sehat, include self-awareness, okay, include the home environment. So being involved in involving the parents is better, whether they have knowledge or not, and whether they continue to practice or not after the intervention, as well as whether there's support or not from family, from the researchers, school teachers, and so on. In terms of barriers, sometimes peers of the children, they are barriers because they make fun of the children, so the children are too shy to exercise and so on, or they want to do physical activity but nobody wants to play with them, so that's a barrier for them. Some of them might be tired of the program, they felt bored, okay, or they are too busy, too shy. There might be some safety reasons, okay, as well as whether there's a consistency of the intervention or not. If we don't go back, they will forget about it. All right, moving on. Toy Box Study Malaysia. I think I'm at 3:30, so I'll move very quickly. So Toy Box Study Malaysia is an intervention for preschool. We have 4 modules, okay, and we conducted it with Kemas kindergartens in KL and Sarawak. And we co-created this theory of change about how to implement the project. And this is the timeline for us to implement. Is similar to the other 2. We had pre-measurements and we had post-measurements done. And the results you can see is that BMI for HZ score among the overweight and obese children, the red color lines, have actually dropped as compared to control group. Okay. We've published this paper about process evaluation. You can have a look at it online. We've also published about the teachers and parents' perspectives about the overall Toy Box project. Is also available for free, I think, online. These are some of the pictures from our Toy Box physical program, okay, with children having their suku-suku separuh plates and so on. Classroom activities, we brought them for an outdoor activity in KL. We went to farm in the city. And then Toy Box Study Malaysia ended. So we are very lucky to be able to get another grant, and it happened also at the same time as COVID started. So we converted Toy Box Study Malaysia to e-Toy Box. So it's now available online. So preschool teachers can log in and they can look at various animation videos, demonstration videos, infographics, and storybooks, and so on. We've done content evaluation for this study, and basically we found that it has high overall average scores for understandability, actionability, as well as satisfaction. In terms of usability evaluation, we did using this questionnaire called PSSUQ, and the lower the score, the better it is. So there's positive user satisfaction. And we also did semi-structured interview where the teachers reported that they found the e-Toy Box to be appealing, useful, and it helps to motivate them to teach to the kindergarten children. So for the Toy Box, we managed to get 2 Newton Fund grants, okay? And this is our team, and I don't forget also to thank the Toy Box Europe people who allowed us to modify the program into Toy Box Study. I just have a few more slides to go. So looking at all these Cergas interventions and toy box and so on, is it enough? We are actually tackling people at the individual level. Is tackling each individual enough to make changes so that our whole population is healthy? If we look at this socio-ecological model of health, it actually is not enough. So we know that the food environment can impact health behavior. There are various factors, like from the farm to the market to how we eat and where we eat and so on, and how we are bombarded with advertising and so on. So for that, we started another project called the Southeast Asia Obesogenic Food Environment Study. And this one looks at the retail food environment. Those of you who joined us a couple of days ago for our stakeholder presentation of the CFS study, you would know the results in detail, but I don't have time to share so detailed with you today. It also has 4 countries, Indonesia, Malaysia, Thailand, and Philippines. And the study was conducted in 4 phases, basically to look at overall retail food landscape, to look at consumer perception, retailers' decision-making, as well as the policy landscape, and not forgetting engagement of stakeholders throughout the project. This is a finding. Basically, in short, in Malaysia, Thailand, and Philippines, food retail, people mostly go to the modern as well as the traditional food retail. But in Indonesia, mostly is still traditional food retail. Okay, people still mostly go to the traditional markets in Indonesia. These are just some pictures of what is traditional and what is modern food retail. The major players for Malaysia is 99 Speed Mart. And using the AHP process, we decided that we should study, well, not we decided, the panel of experts suggested that we should study hypermarket, supermarket, and convenience store, which is the modern format, because our study was conducted in KL, so most people would shop there. But we also have feedback from other people that we should look at the wet markets, where a lot of people go to wet markets to buy food. And we've actually conducted that outside of the CFS study to look at how people purchase foods in the wet markets. Okay. From phase 2, some of the factors that influence food purchase behavior include where is this place that you are going to do your shopping? What's the price and promotion factors? Might be people and physical evidence as well, including friendly staff and so on, as well as quite important product characteristics. Are the food safe and so on? Now, another project which is called System China SIAX. This project is also focusing on Southeast Asian cities, but in this study, Southeast Asian cities, we were mostly looking at scoping reviews. But for the China city, it was actually conducted, the study. So this project is not led by me, it's led by Li Pai, and you've met her if you attended last year's Obesity Week Malaysia webinar. She gave a presentation on this whole project. But today I just share with you a little bit about this. So basically, when we talk about the food environment, we are not just the food environment, about the environment that can influence nutrition, whether we have malnutrition or we're having good nutrition. It's all sort of sectors. So we need to really look at it on a systemic basis. So for this System China SIAX project, phase 1 has been completed at the last year, okay? And the plan is to move on to phase 2, and we are currently working on the grant application for phase 2 from Wellcome Trust. It's a very, very big project. We've been working on the grant application for at least 6 months, and we have about a month more to go to finalize the grant application. All right, so from the phase 1 of System China SIAX project, we came up with this systematic review, which has been published. You can go and read on it. I don't have time to tell you the results even. And we also have this paper about group model building. So group model building is how you can come up with all these conceptual framework of what leads to what leads to malnutrition, basically. Okay. So overall, my last slide. So as a conclusion, we know that Malaysia is still grappling with the triple burden of malnutrition, and we need good nutrition policies that can help our Malaysian youth as well as the overall Malaysian population to become healthier and to reduce the malnutrition rates. So we need to really think of what is the effective strategies. Just doing nutrition education might not be enough, and we need to consider the bigger picture, looking at collaborative efforts between different agencies, which Prof. Tila also talked about just now. So before I end, I just want to acknowledge all these people and all these project team members and all these grants that have funded my research. Thank you.
Thank you, Prof.
Enough, Geeta.
Yep, thank you, Prof.
Okay. Yeah.
Sorry, you had to rush just now.
It's okay. I
Quite
realized it was
interesting
3:30.
findings over there,
Yeah.
but in the interest of time, I guess we had to move on. But I have one last one quick question, Prof.
Okay.
So you mentioned about your studies that you conducted at schools. I'm wondering whether the sustainability of the intervention that you have taught the children, the parents, to a certain extent to the teachers as well. Have you evaluated them? Do you think that will last very long? Or if not, for how long do we need to revisit to those things, those interventions? What do you think, Prof?
I think if you look at the Juara Sihat results, right, it's very clear that these are children from primary 3, 4, and 5, right? It's very clear that we teach them for 12 weeks, and then 12 weeks later, they have forgotten like half of what they learned already. So it's not very good. For sustainability, so just now I shared sustainability of Juara Sihat, but actually the student who did this study was Wilfred, and you all know Wilfred. He did sustainability for Cergas as well as Juara Sihat, and one more, which is the Great Child Trial, which is Pichin's PhD project.
Yeah.
And when we followed up at about 1 to 2 years later, people would still remember, oh yes, we were involved in that program, but they would have forgotten, like actually.
Okay.
Yeah. So that's why nutrition education, unless we keep on bombarding people with the same information over and over again, they will forget. So having this bigger picture, like what we are doing for SPOM, looking at it from a bigger picture, how we can change the environment, I think is very important.
Right. Yeah. So that's why I was trying to ask this question, because I'm trying to link with what Prof. Tila have presented and with what you have presented in terms of sustainability and monitoring of this intervention that seems to be effective, but how long? Yeah. And the question is like, how long and how many times do we need to intervene them? And because these are not cheap. This is very expensive, because it's very extensive and a very expensive.
And then you only reach this group of people. Whereas if you change the environment, everyone can benefit from it.
Yeah. True. Yes. So we make the environment as a default option for everybody. Yeah. Okay, so with that, thank you so much once again, Prof. For your time and your very well done presentation today, as usual. Thank you so much, Prof.
Thanks.
Okay, we should move on to the next speaker. Prof. Hatim is already here. Prof, sorry, kita slightly running over the time. Yeah, I hope you don't mind. So let me introduce Prof. Hatim first. Yeah, Prof. Hatim Sulaiman is a professor of psychiatry at the Department of Psychological Medicine, Faculty of Medicine, He is the president of Malaysian Psychiatric Association, the vice president of the Pacific Rim College of Psychiatrists, and council member of Asian College of Neuropsychopharmacology. Betul ya, Prof? quite long. Yeah, his main research is on the psychopharmacology of schizophrenia, bipolar depression, and drug addiction. He has served on many national and international scientific committees and advisory boards, has spoken at numerous conferences, and is also a member of editorial board of International Journal of Bipolar Disorder, Asia Pacific Psychiatry, and Malaysian Journal of Psychiatry. Has published many, I can see there, many, take my word, many publications and quite a number of citations over there. He has served as a consultant and principal investigator for multiple national and international pharmaceutical company, including clinical trials in the field of psychopharmacology. Prof. Hatim will be speaking about the neurobiology of craving. So one of the important topic for most of us, especially at this hour of the day, the cravings kicks in, Prof. Yeah, so it's a very good timing, I suppose. So over to you, Prof.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. A very good evening. Thank you very much, Prof. Geeta, for the kind introduction. Thank you to Maso for inviting me here today. And thank you to iNova also for sponsoring this session. It's a great pleasure to be speaking to all of you. So let me share my screen first. Can you see my screen?
Yes, Prof. If you put it in the slideshow, yes.
Just hold on. Okay. It's not. Does it go to slideshow yet or not yet?
Belum lagi.
Belum. Okay.
Better. Yes, thank you.
Okay, so I'll be talking about the neurobiology of cravings. I'm not the expert in terms of obesity, but probably there's some relationship between the obesity and addiction. It's not direct, but there's some concept similarities. So I must apologize that this topic is a bit heavy and dry. It's quite difficult for the audience to digest, I think, in the after lunch. So I'll try my best to cover on the neurobiology of cravings. So this is the disclaimers. If anything wrong that I say, please don't blame iNova. The slides are actually prepared by myself. Okay, many of us have experienced an intense urge to eat a certain food, sometimes right away. And the food is likely to be sugary, salty, or fatty, or most of the time, all three of them. And you may feel increasingly excited even as you imagine how it will taste and how you feel eating it. So, and maybe you just ate several hours ago, or maybe still digesting your last meal. And these urges are called cravings, which can pop up any moment and not always fueled by hunger. But when you're hungry, then the craving becomes more. The people used to have the term sugar addict or chocoholic, but and people may blame cravings on a sweet tooth, bad eating habits, or lack of self-control. So to a certain extent, this may be true, but actually cravings involve a complex interplay of factors involving brain messages, behaviors that become habits over time, and also because we have easy access to food. There's a lot of animal and human studies shown that foods that stimulate the reward regions of the brain influence our food choice and eating behaviors. So when we eat certain foods, the neurons in the reward region become very active. So creating highly positive feelings of pleasure so that we want to keep eating this food regularly. These are the type of foods that sometimes labeled as hyperpalatable because they are easy to digest and have enjoyable qualities of sweetness, saltiness, and rich in fat. These hyperpalatable foods can stimulate the release of metabolic, stress, and appetite hormones, including insulin, cortisol, dopamine, leptin, and ghrelin, all of which plays a role in cravings. So normally, when eating a meal, appetite hormones are released. So this includes several neurotransmitters like dopamine, cannabinoids, opioids, and serotonin, as well as neuropeptides, which involve in homeostatic regulation of food intake. Example such as orexin, leptin, and ghrelin. All these neurotransmitters and neuropeptides are implicated in the rewarding effect of food. Glucagon-like peptides and cholecystokinin from the digestive tract, leptin from fat cell, these two can cause feeling of fullness. So they can communicate with the brain and force us to stop eating. So if the body haven't received food for several hours, ghrelin is released from the stomach to signal hunger. So eating hyperpalatable food too often might interfere with how the brain processes these hormonal signals, so that one may feel continued craving despite still feeling full, or despite we have eaten enough food. And animal studies have shown that signal can become disrupted when eating a very high sugar or high fat diet, which may trigger the release of hormones that reduce stressful emotions, therefore lead to habitual desire for these comforting foods. That means when we stress, we eat, and when we eat, we feel better. So we try to compensate stress by eating. And interestingly, human studies have also found association with strong cravings and artificial sweetened food and beverages, as their intensely sweet flavor may produce the same rewarding effect as sugar. So it's not just sugar, but the artificial sweetened food can also cause in craving. So what is the reward region of the brain? So different areas of the brain make up the reward system, but the key part of the brain related to cravings and regulating appetite is called the hypothalamus. So it is a tiny pea-sized area that comprises less than 1% of the weight of the brain. However, it regulates the secretions of chemicals and hormones related to stress, pleasure, and hunger. Neurotransmitters in the hypothalamus, such as dopamine, serotonin, endorphins, are the feel-good chemicals. These chemicals send messages to the other nerves to signal positive emotion that are associated with rewarding experiences. So the expectation of receiving a reward, when we expect that something good is happened, so not necessarily the reward itself already stimulates the dopamine activity. So dopamine release is even higher or larger if the reward is greater than what we expected, which may stimulate a person to seek the experience or eating the food or getting the substance again and again. So this is some of the basis of addiction. So eating certain foods repeatedly that stimulate the reward region is believed by some researchers to lead to so-called addiction food behavior or emotional overeating. So you can see here there's a complex relationship. There's a lot of system involved that regulates our appetite, satiety, food intake. So there's multi-layer, multi-system involving the reward, cognitive homeostasis, and also involving a lot of neurochemistry, neurochemical, neuropeptides. So it's a very complex interplay of all this system. However, we can simplify it into two main systems, which is the mesolimbic reward system and the hypothalamic hunger system. So the mesolimbic reward system basically controls the motivation, reward, and reinforcement. So it evolved to respond to very high fat, high sugar food, and this is partly to aid survival because high fat, high sugar have a lot of energy for survival. And dopamine and opioid signaling known to play a very important role in this mesolimbic reward system. And activities seem to be altered in obese patients or population. And also associated with reward-based eating behavior and craving in food plentiful environment. So there's a lot of food, so it enhances further this craving. And the other system is the hypothalamic hunger system. That's integration of the peripheral signals, hunger, fullness, or fat stores to modulate feeding behaviors and energy balance. This involves leptin, ghrelin, and all the other hormones that can also affect the food intake system. However, the mesolimbic reward system can override the hypothalamic hunger system. So this leads to increased consumption of food even when we are not hungry. So there's another concept that I want to introduce is this what we call wanting versus liking. So both sounds like almost interchangeable, but there's a slight difference between like and wanted. So wanting is the attention grabbing and motivational features of reward and their learned cues. So reward cues have the ability to often trigger bursts of rewarding seeking motivation, and the cue itself becomes attractive as a motivational magnet. So this is how the advertisement works. Even before you taste the food, you already want it. Yeah. So there's association with a lot of dopamine release just by wanting. So liking is the actual pleasure impact of the reward consumption. So brain reward system involved with food intake, distinguish mechanism involved with motivating this desire for the food. So referred as wanting. Versus as a mechanism involved with the hedonic properties of the food, referred as liking. So the dopamine striatal system is predominantly implicated in wanting, whereas the opioid and the cannabinoid system are predominantly implicated in food liking. So this has the implication when I talk about the treatment later on, the pharmacological treatment later on. So the brain imaging studies in humans have shown that dopamine release triggered when humans encounter food cues related with their subjective ratings of wanting the food. And conversely, the activating of endogenous opioid or cannabinoid receptors appear to stimulate appetite in part by enhancing the liking or the palatability of the food. Although these two mechanisms looks like are separate, but they act in tandem, in concert to modulate eating behaviors. So certain foods have the ability to keep us coming back for more and more, but it's not the same manner as drug or alcohol addiction. So it's too strong to say that food craving is an addiction. A food craving is an intense and persistent desire for food, but the food is not necessarily always for something that is delicious. It can also be caused by nutritional deficiency, boredom, or self-imposed food restriction. Food addiction is a one step beyond, including not only intense craving, but also exhibiting a loss of control of eating behavior and repeated excess consumption of food, especially the hyperpalatable food. So what are the similarities of addictive substance and hyperpalatability food and how they affect the brain? So both activate the same pathway, triggering dopamine signals and the reward learning regions in the brain. And both can lead to a need to use increasing amount over time due to tolerance. So this is another definition in addiction, which is tolerance, which is caused by changes in the brain signaling. So both are associated with difficulty in quitting due to a hyperactive response in the brain reward region when the substance or food is present. So animal studies have shown that hyperpalatable foods and addictive substances can cause imbalance in the brain's reward system. So normal eating patterns are regulated by brain response in the hypothalamus with the release of appetite hormones and chemicals so that one eats when hungry and we stop when full. It is also believed that this reward system is overstimulated and disrupted so that a person may continually seek specific foods, especially when feeling negative emotions like too much stress. So sometimes people eat when they feel stressed. The repeated behavior over time of using hyperpalatable food to produce pleasurable or calming emotions with the release of dopamine can condition the brain to seek out this response. So because of this, food release a lot of dopamine, which cause a calming effect. So people go for more and more of this food, especially when they are stressed. However, if there's decreased response of the reward system, for example, less dopamine is secreted, one may experience less satisfaction after eating. So as a result, one may eat larger amount of this hyperpalatable food to try to achieve the same reward response. So this is what we call tolerance. Yeah? So similar effect can be seen in drug addiction because the patient needs to take a higher amount of drugs to achieve the similar effect. So similarly, the person needs to eat more and more every time to feel satisfied. And animal studies have shown that when cortisol is released with chronic stress, changes in the brain response can lead to lower dopamine level and increased cravings. And stress have also been associated with increased levels of hormones like ghrelin, causing stronger cravings. So high intake of sugar has been studied to disrupt the body's natural ability to sense hunger or satisfaction, so that people may keep eating despite being full because of this disruption, which can alter the body natural homeostasis. So a review of clinical trials looking at the relationship of highly palatable sugary foods and negative emotions such as stress, anxiety, depression, and fear found sugar to have addictive effects and cause changes in the brain chemistry similar to other active substances, and the ability to produce negative withdrawal symptoms when stopped the sugar intake. So another model that can explain craving is what we call the classical conditioning model of food craving. So this is based on the classical conditioning, which is a Russian psychologist who studied the digestion in dogs. So in his study, Pavlov paired a behavioral procedure in which a biological potent stimulus, which is food, is paired with a neutral stimulus, which in his study is a sound of a bell. So initially, Pavlov noticed that his dog began to salivate in the presence of the technician who normally feed them. So even before seeing the food, the dog already have anticipatory salivation. So then Pavlov did a study where he presented a stimulus, which is a bell ringing, and give the dog food. After a few repetitions, the dog started to salivate just by hearing the bell sound, even though when there's no food. So this is again the pairing consumption of certain food with external, like watching television, or internal stimuli like feeling sad, and also advertisement, you know. So just seeing the advertisement, you already salivate and start feeling excited about the food that you like. So this can again induce a lot of craving. So what are the other factors that affect cravings? These are some of the factors, include food industry advertising, stress, I mentioned earlier, sleep, exercise, hormonal changes, and of course, some medications. So let's look at briefly on all these factors. So food industry advertising is very huge. Yeah, I think food industry spends billions yearly on snack food advertising. So many snacks fall into the category of hyper palatable food. Then that can stimulate the brain reward pathways. So this food includes potato chips, crackers, ice cream, candy, fast food meals, which have high amount of sugar, salt, and fat that send messages to the brain so that you can keep on eating them. So just watching a 30-second advertisement on television or in TikTok or in the social media, or even just seeing a photo of this delicious food can spark cravings. And many ads for unhealthy snacks, food, and beverages unfortunately directed toward children and are considered a key component in the environment that promotes overeating, poor dietary behavior, and obesity. And children have the highest exposure because their screen time throughout these devices for recreational activity, whether it be television, social media, handphone, or online gaming. And increased exposure to this food advertisement is associated with high calorie intake and increased preference for hyperpalatable food resulting from this advertisement. And surprisingly, educational website also rank in the top 10 for snack, sugary drink, fast food, and sugary cereal ads. What about stress? So during acute stress, the hormone adrenaline suppress our appetite. But with chronic stress, there's cortisol level increase, which cause craving, particularly for foods high in sugar, fat, and calories, which leads to weight gain because the body sense that we need high energy from the stress. So this association may be caused by disturbance of message to the brain that cause the release of cortisol, which stimulates our appetite and cravings. And cortisol favors the accumulation of fat in the belly area, also called as central obesity, which is associated with insulin resistance and increased risk of type 2 diabetes, cardiovascular disease, and certain cancers. It also lowers the hormone leptin, which is leptin normally promotes satiety, and increase the hormone ghrelin that increases appetite. What about sleep? Epidemiological studies shown that insufficient sleep is independently associated with a higher risk of obesity. Clinical studies of sleep-restricted adults show an increased hunger and calorie intake when participants are allowed free access to food. A preference for late evening or nighttime food intake and increase in snacking has been observed in this adult. There also appear to be a food preference for higher carbohydrate and fatty foods, which could partly explain the overall higher calorie intake. Changes in the hormone level that signals either hunger or satiety have also been observed in clinical sleep restriction studies. Leptin is a hormone associated with satisfaction. So when food enters the stomach, leptin is released from the fat cell and travels to the brain, where it signals the body to stop eating by creating a sensation of fullness. People with obesity may actually have very high level of leptin. So the more body fat one have, the more leptin is produced in the fat cells. However, there's a condition called leptin resistance may occur in which the brain does not receive the usual signal from leptin to stop eating. In response, more and more leptin is released. So low leptin levels as well as high leptin levels suggesting leptin resistance have been observed in leptin deprived adults. And ghrelin, the hunger hormone, typically has the opposing action of leptin. So it is released in the gut and sends hunger signals to the brain when someone is not eating enough. About 3 hours after eating, ghrelin levels drop. And clinical studies have found that sleep restriction leads to elevated ghrelin level. Next, let's look at exercise. Exercise typically lowers level of appetite stimulating ghrelin and increase appetite suppressing leptin and glucagon-like peptide, at least during the short-term period. However, there are several factors that can influence how much exercise affects one's appetite. So the longer the duration and the higher the intensity of the workout, the more likely one's appetite shuts down, as blood is moved quickly away from the gut and to the heart and muscle to supply oxygen. And after exercising, normal hunger signaling gradually resumes. A shorter, less intense workout, such as a moderate walk on the treadmill for 20 minutes, may not have any effect on the appetite. What about hormonal changes? So in women especially, hormones fluctuate during various phases of their menstrual cycle. So when estrogen levels are low and progesterone is high, so the women may feel increased craving and less satisfied after eating. So our brain have the receptors for estrogen, and high level of estrogen are associated with fullness and satisfaction after eating. Estrogen also suppress hunger by decreasing level of ghrelin and increase effectiveness of cholecystokinin and appetite suppressing hormone. So more research in this area has been with animal studies, but it's a topic of ongoing interest, especially in women who experience weight gain and have low estrogen level due to menopause or medical treatment that suppress estrogen, example, those on chemotherapies. And finally, let's look at medications. So some medications, for psychiatrists, we give a lot of antidepressants or even antipsychotics to our patients. And these two types of medications can actually increase appetite and induce weight gain. And these medications basically interfere with the neurotransmitters, the serotonin, dopamine, which regulates the person's mood and appetite. Another medication that can increase appetite is actually steroids, prednisolone, given to lower the cortisol level with certain health condition. Prednisolone can promote leptin resistance so that leptin does not work properly to suppress appetite, causing one to feel persistently hungry. So now in the next few minutes or so, I would like to focus on the pharmacological aspect of weight management, which is I'll talk about Contrave. So Contrave is a relatively new medication that can help in patients with obesity. So it is a combination of bupropion and naltrexone. So individually, naltrexone and bupropion each target pathway in the central nervous system that influence appetite and energy use. So bupropion is a reuptake inhibitor of both the norepinephrine and dopamine. So it also activates the pro-opiomelanocortin or POMC neurons in the hypothalamus, which give an effect resulting of loss of appetite and increased energy output. And the POMC is also regulated by endogenous opioids via the opioid-mediated negative feedback. Naltrexone is a pure opioid antagonist, which further augments bupropion activation of the POMC. So the combined naltrexone bupropion has an effect on the reward pathway that results in reduced food cravings. So as a psychiatrist, I use naltrexone and bupropion before, mainly to treat addiction, opioid addiction. For naltrexone, bupropion is more for nicotine addiction, and bupropion is also an antidepressant. Yeah? And when they combine bupropion and naltrexone, it has shown to be effective in hunger reduction and also reducing the craving. However, the exact neurochemical effect on Contrave leading to weight loss are not fully understood. So the hypothesis is that it affects the mesolimbic reward system. So the combined naltrexone and bupropion reduce food intake when injected directly into the ventral tegmental area of the mesolimbic circuits in the mice, and area associated with regulations of reward pathway. And combined naltrexone and bupropion increase the firing rate of the POMC, pro-opiomelanocortin, and which are associated with the regulations of appetite. So again, this is how the medication works by decreasing the appetite by direct effect of the bupropion on the POMC neuron activation, and the indirect effect of the naltrexone also on the POMC neuron activation. So as a result, there's increase in PMOMC activity, reduce in hunger, and reduce in weight. So there's at least 3 clinical trials to support the efficacy and safety of Contrave among patients with obesity. So I just go through it quickly. So these are very obese patients with BMI of more than 36. And you can see that this randomized controlled trial in this study comparing Contrave with placebo over a 1-year period. And you can see that as early as 4 weeks, there's significant reduction in weight in patients taking Contrave compared to placebo, and continue to show further improvement up to 56 weeks, or at slightly more than 1 year, with 8.1% reduction in weight compared to only 1.8% reduction in weight among patients with placebo. And it also promotes change in eating habits. In example, how hungry they felt, how full they have felt, how difficult to control eating, how to resist any food craving, and response to food craving. And in this study, comparing placebo with behavioral modification plus versus Contrave with behavioral modification. So one group was only given behavioral modification, the other group was given behavioral modification with Contrave. And see again, there's significant improvement when we add Contrave to the behavioral modification group as early as 1 month. Further improvement can be seen up to 1 year, with more than 7.3% difference among female and 11.5% difference among male patients. And there's also reduction in waist circumference, not just weight reduction, there's also reduction in waist circumference in all 3 studies. There's also reduction in the triglyceride level, an increase in the HDL cholesterol level, which is a good cholesterol when they are put on Contrave. And even among patients with diabetes, there's significant reduction in weight. This is another study comparing patients with diabetes who have obesity. And there's better control of the HbA1c when it's combined with Contrave compared to only placebo. So what are the indication use of Contrave? So Contrave is indicated as an adjunct. So it's as an adjunct to a reduced calorie diet and increased physical activity for the management of weight in adult 18 and above. So it's not indicated for adolescent and children. Yeah? So it's only for adults who have obesity or overweight with presence of weight-related comorbidities. That means the patient is overweight but have diabetes, dyslipidemia, or hypertension. Or if they are obese alone, then you can also use Contrave. And treatment with Contrave should be discontinued after 6 weeks if the patient does not lose at least 5% of their initial body weight. So what are the common side effects of Contrave? So the most common side effects is nausea, headache, dizziness, and vomiting. And the nausea normally occurs during the titration period. So you have to titrate the dose over 4 weeks period. So the first week you just give once a day, 1 tablet a day. Second week you give 1 tablet 2 times a day. Third week you give 2 tablets in the morning and 1 tablet at night. And then the 4th week, 2 tablets BD. And it can cause increase in blood pressure. So, and also increase in resting heart rate. So you have to monitor the blood pressure and make sure the patient's hypertension is well controlled before starting on Contrave. So what are the contraindication? Should not be given in patient with seizure disorder, patient with history of bipolar disorder, because bupropion is an antidepressant which can cause an effective switch. If the patient's on opioid, some patients are on painkiller, so they should not be given Contrave because naltrexone can block the opioid receptor and cause extreme severe pain. If the patient's on monoamine oxidase inhibitor, which is very important for the metabolism of the medication, patient with severe hepatic impairment, end-stage renal failure, or among patients who are pregnant. So my last slide in summary, food craving can be defined as a motivational state that encourages consumption of food. Taste, pleasure, or enjoyment of food is determined by the opioid system. On the other hand, the desire for food is determined by the dopaminergic system. Craving is associated with brain changes produced by food, and such changes in turn cause some psychological changes. So two central nervous system pathway, the hypothalamic hunger system and the mesolimbic reward system, play key roles in regulating eating behavior and weight. So Contrave, a novel agent, has a dual acting mechanism of action believed to work synergistically to reduce hunger via the hypothalamus and blunt the rewarding aspect of the mesolimbic reward pathway. So with that, I'll thank you for your attention.
Thank you, Prof. Hatim, for a very comprehensive talk on the neurobiology part of cravings. As much as we thought it's all as simple as cravings, can sometimes it's just I'm craving for something, but there is a lot of things happening in our brain that makes us to crave to certain the way we we want to eat certain food. So well done, Prof. That was really very insightful. Yeah, Prof. I have one question. Before I let others to ask, maybe they're still thinking of the question they want to ask you, Prof. About the food craving and the stress eating just now. I know I'm guilty as charged lah. Stress eating ni cannot be avoided sometimes. When you have too much of stress, at work and so on. Just wondering if in terms of stress eating, what about we are still mindful with what we are eating. We eat in moderation, and we restrict certain food or the quantity of certain food. Will that be affecting our cravings at the subsequent consumption of food?
Okay, thank you for the question. Actually, craving is not all or none. It's a degree. So there's a level of craving. So sometimes if your craving is too difficult to control, even you are mindful, you cannot resist the craving. And it's also depends on the environment and the level of stress that you have. Because when you're when you are stressed, one of the way to relieve stress is by eating, because I've mentioned earlier, when you eat, there's release in dopamine, noradrenaline, which makes you feel good. Normally these are high sugary food and high fatty food that stimulates the mesolimbic area. So again, that's make it difficult to control, especially you are very stressful environment. So it's best to find a more adaptive way to cope with stress. So instead of eating, then exercise is also a better, and because when we exercise, the brain release endorphins and caffeines, which also release the stressful situation or level. So it's stress eating normally can be overcome with exercise and enough rest or sleep. Because when you don't have enough sleep, then you feel stressed, then this compound effect and synergistically increase in food cravings. Yeah.
Okay, thank you so much, Prof. So the way of coping with stress is to do some other healthy
Healthy, yes.
activities and so on, like exercise and so on. So that's really very good. Thank you. Another question I wanted to ask you, Prof, regarding wanting versus liking just now. Is there any similarity in the way of how certain people eat, when they want or when they like something? So, or it doesn't matter?
Actually, it's combined. So when you start wanting something, your dopamine already start. So dopamine is like a motivation neurotransmitters. So it motivates you, it lights up, so it pushes you to get something. And if there's cue from outside, for example, there's the environment, or there's a certain smell, or there's certain visual excitement, so your dopamine starts to release, and it starts go to your memory level, and you already remember the past experience, and you already start to feel good. Even you haven't tasted the food, you already know how the food tastes and how it impact you. So that's the one thing. So one thing is very powerful for addiction. That's why when you notice that those who went for pusat serenity, for example, 2 years they can be without drugs, no problem. The moment they step out from the serenity, they saw their old friend, they saw their pot where they have their injection, they start wanting the drugs. The dopamine starts flaring up in the mesolimbic system. And the liking is when actually consuming the substance or taking the food. So enjoyment of the food itself is liking. So that both are very powerful, but the one thing is the one that leads you to go looking for the food or for the craving. So both have impact actually.
Great. All right. So thank you so much. And I have Prof. Ismail. Yes, Prof.
Yes. Thank you, Geeta. Thank you, Prof. Ahmad. The first time I've seen, it's very comprehensive. I mean, it's easy for us to assimilate being not in your area. But I'm intrigued with one of your conclusion that says contrave is indicated as an adjunct.
Yes.
Yeah, to reduce calorie diet. Are you trying to say that it would work in people who are eating not the normal calorie? I mean, does he has to be somebody that is already on a low calorie diet before contrave can actually work?
Okay. Thank you, Prof, for the question. So actually, in psychiatry, we always go for what we call biopsychosocial management. So it works best if you have multiple prong of management. So you're just giving medication without behavioral modification, without trying to exercise, without trying to alter your habits, and without trying to control your stress level, the success will be much lower. So it's less sustainable. If you are able to change your eating habit, do an education on what is what is high calorie diet, what is low calorie diet, what is healthy, unhealthy, pair it with a good exercise. So it's more sustainable, because you just depend on the medication, it is not the success rate will be lower and sustainability won't be achieved. So that's the why I put that the indication must be in as a junk, not as this, because human being, they're like a shortcut, you know. So just one take tablet, everything will go, and just continue eating ice cream, taking the chips. So it won't
that's
help.
That's what I'm hoping that has come up with something. Because earlier, your earlier slide said most of the medication actually doesn't check cravings. Kan? Like in fact, it do the other, increase craving.
Yeah.
But I was hoping that there is a drug that must be a drug that can control craving.
It does control craving to a certain extent, but the FDA approval said you must in conjunction with behavior modification.
Like the drug. Take care of your diet and exercise.
Yeah. Because if you just take the drug, you might not be.
How long has this been in the Malaysian market, and how much it costs?
The cost, I think I have to refer back to the Innova, right? I don't have the privilege to announce it, because they probably have different costs for different centers. So you have to contact Innova reps, unfortunately, Prof. So I think probably Prof Geeta can distribute the number of the rep to the participant to get more insight about the country.
Okay, thank you, Prof. Thank you, Prof. Hatim, for reassuring that now our role as a nutritionist dietitian is still relevant in this field. Okay, I have one question from in the chat box. Yeah, what can we do to stop the cravings? A very general question.
So it's like I mentioned earlier, it's very complex. Craving is a very complex condition. So it's not an easy thing to deal with. So it deals with a lot of cues, and there's a lot of environmental factors. There's a lot of neurobiological factors as well. So it involves, like I mentioned earlier, it involves a biopsychosocial approach. So in terms of biological, we can use medications. So like Contrae, for example, who have effect on the mesolimbic system to reduce or to normalize the dopaminergic system, and to normalize the opioid system, to normalize the wanting and the liking system. And environmentally, you also have to change the way how your healthy lifestyle, to how you manage your stress, adaptive way of managing stress, which can again reduce the craving. And also exercise, get enough sleep, because all these affect our hormone level, our neuropeptides, our neurotransmitters, even though it doesn't look like that way, but actually all these have huge implications on our brain. Exercise, sleep, stress management. So these are multiple ways to reduce cravings. And also the environment. So probably make it less easy to get ice cream. Don't buy chips. Don't stock up hyper palatable food at home, so that you more difficult for you to access for it. Then probably you have more difficult to gain the cravings.
And that's very, very good answer, Prof. Hatim. So thank you so much. So I think it's almost 4:30 now. So thank you so much once again, Professor Ahmad Hatim, for your very insightful talk. And as Prof. Ismail said just now, it's very comprehensive. We can, as a layman, I can really understand a lot of neurobiology aspects of craving. So it's not as easy, but of course, lifestyle intervention works the best in this sense. So thank you so much once again.
Thank you.
To see you again in muscle programs in future. And thank you for Innova as well for sponsoring this your talk. So ladies and gentlemen, we have come to the end of this webinar, second webinar in this Obesity Week Malaysia. Thank you once again for your support. It's all very important for us. We had almost full house just now, 100 participants. Of course, now it's reducing. So I hope to see all of you once again in next events and activities that we're going to do. Please follow our social media account so you will know what we are up to in the next months and so on. Yeah, okay, thank you so much. And the attendance is there. Dr. Simeng already shared the attendance earlier on, attendance for this webinar. Please enter your details so that we can send the e-certificate to you directly after this this webinar, probably in a week time. Yeah, so give us some time because we need time to produce the e-certificates. All right, so thank you so much, and once again, that's all for today. Thank you.